So my name is Drew St. Laurent. I am the Senior Operations Manager at the Centre for Excellence in Indigenous Health here at the University of British Columbia. My background is, on my mother's side, I'm Cree Métis from Winnipeg, Manitoba, Treaty 1 territory. On my father's side, I'm German. A little bit about my educational background. I had a fairly tumultuous relationship with the K through 12 system. It was one that really didn't work too well for me. I didn't really know where my spot was there and how I fit. And then I got into university and found a true calling here. I certainly wasn't judged. I came in, teachers didn't stereotype me right away, and ended up with a human geography degree from the Thompson Rivers University in Kamloops, British Columbia. I came to the University of British Columbia and I did a year and a baccalaureate in education, where I taught in the school system for 3 years in the North Vancouver school system, and then came back with my true calling here, which is to work in administration at the University of British Columbia. I did a master's degree here as well within educational studies. Some of the initiatives that we have going on at the Centre is we're really excited, and I'm sure you would have heard this from Marshall as well. We're hosting our very first institute in August for Indigenous public health professionals, specifically from Indigenous communities. This is groundbreaking work that's been done. It's passed through UBC Centre, so we're really excited to get it going. But many of the target audiences are actually not students or students that even meet the threshold of becoming students at UBC. We feel very strongly that we need to bring in community members to be leaders in their Indigenous communities, to come to UBC to learn about public health, to talk about the challenges that are going on in community, rather than bringing in students that are already here that are privileged enough to be here. So that's one of the initiatives that we have on the go. Another one that we're really proud of, and I hope Carrie Ann had a chance to speak to it, is 2324, which is taking into account Truth and Reconciliation calls to action numbers 23 and 24 specifically around Indigenous healthcare providers. And we've been able to roll that out to all first year professionals within health sciences. So you're looking at occupational therapists, physical therapists, dentists, kinesiologists, dietitians, physicians, nurses, the list goes on, and it's something that we're incredibly proud of with the work that we're doing. That's a good question. It was actually during my time as a teacher where I started to realize that the conversations that were going on in the lunchroom were stereotyping and marginalizing a lot of people, and those are some of the things that really ate at me when I was going through my high school entry time. So that stereotyping of, well, this student can't do this because, or this student will never get higher than a C+ because they're not capable of it. Breaking down those barriers was something that I was incredibly passionate about. And right from the get-go, at least in my experience, being Métis, I was already stereotyped as being something other than the norm. And I felt like I really missed out on a lot of opportunities because of that, and I wanted to really start to break down those barriers. And I feel that with what I had already said at the Centre, with what we're starting to do, we're able to take advantage of that. So I was born in Winnipeg, Manitoba, and have a very strong connection there still. But I moved away from Winnipeg when I was 2 years old. My father got a job in the mill in Powell River. We moved to Powell River, which is in Coast Salish territory, not where I'm from, not the territory of the Cree people. So my relationship to who I am and who I was very different than that of the local First Nations group in Powell River. So I wouldn't say that I necessarily fit in, and I was struggling with who I was as who I identified with. I see a large need in training Indigenous professionals to work in the healthcare system within their own community. One of the major challenges that I've seen that my family talks about that are living in rural areas in Manitoba, I'm from Winnipeg, but some of my family members don't live there. They live in rural communities, and often there's what we call fly in and fly out. So you'll have a dentist come into a community, fly in for 2 weeks, see a whole host of patients, and fly out. Is that ideal? I would argue probably not. I'd like to see a full-time dentist in communities that get to know the community specifically so that they can be part of that fabric and understand the needs of the community rather than looking at a patient with a root canal and saying, well, I need to fix this root canal, I can fix a root canal, but not understanding the layers to why the root canal is there. And I could argue that that would be very similar for a lot of the healthcare fields. So if you're going to look at a doctor and that doctor's treating somebody with diabetes, you can treat that, but to get to the root cause, I'm not sure if fly in, fly out works. So training Indigenous healthcare professionals to be in community that understand the needs of community is incredibly vital. I think there's a lot of reasons for that. Lack of opportunity, I would say, is number one. The lack of post-secondary education available, lack of education available and resources available to communities at the 8-month mark of pregnancy, but also being understanding to the fact that this is not their home community, this is not where they necessarily feel comfortable, and this is not where they might not want to be. So, or they might not want to be in that space, they might not want to be there. So I can think of that as an example of where the healthcare system, because it's boxed, if you will, it's not catered to fit one another, that's a downfall. A lot of times the Indigenous approach is based on community, and it's based off of multiple knowledge holders. I would argue that in many cases within the Western approach, there's one knowledge holder. You see the doctor, and then you get referred to another space where you might see another doctor who has specific knowledges in these areas, and then you might speak to a nurse or you might speak to a surgeon. But those are one-on-one interactions often, and they're not based around a team approach, whereas in Indigenous communities, it's based off of the strength of the community, and I think that oftentimes elders are not taken into consideration. At least in the healthcare system with my family, there's never been elders that have been present at a time where there's been a difficult discussion, and I think that the system that we're currently operating under needs to take into account cultural values, especially for Indigenous people, to make the systems systems work together and instead of being at opposition. Okay, I'll give you an example here, and I think this one is fairly salient. Long time ago, before my time, believe it or not, we were in a space in Canada that was very, very, very different. I know that the majority of you are of voting age. I'm sure you go to the polls and you vote. If you don't, I hope you do. Do you see anything odd there? Probably not, right? You go to the polling station, you vote, and you go. It wasn't that long ago where women were not able to vote. And this was something that was very talked about. It was pushed forward to where we had now a time where women are voting. You show up to the voting polls and you don't even think about the fact that a woman has gone and voted, right? It doesn't cross our minds anymore. It's built into the social fabric of who we are and what we know. That's what I would like the marriage to look like. I'd like it to be to a point where we don't see Western and Indigenous perspectives as separate. I'd like to get to a point where we don't even question that, where it's built into the social fabric of our healthcare system, and we're not having this conversation. Yeah, this is a good question. There's a lot, but I'm going to focus on one that I'm very passionate about, and that is I'd like to be able to have Indigenous knowledge holders part of the admissions process at the grassroots. So this is at the university level, into who gets into certain programs. So I know that UBC's medicines program is leading the charge, but they're leagues ahead above of some of the other healthcare professions at UBC. So when an Indigenous person applies to dietetics, why are we looking at the exact same criteria for that Indigenous individual without taking into account their background and their history? So the people that are reviewing their application, are they Indigenous? Do they have a cultural safety and humility background training? Was there an elder involved? How are we measuring Indigenous applications? And I'd like to see a change there so we can work together to have more Indigenous involvement in the healthcare level with communities, with Indigenous students that want to become those leaders, going back to the very first conversation that we were talking about how there's a tremendous need to have Indigenous perspectives from community, and hopefully that's what we're doing by starting our first institute with Indigenous public health perspective focus in August. I think it needs to start at the government level. I'd like to see the government looking at advanced education to come forward with a mandate, and a solid mandate. Perhaps that's percentages of seats in certain programs, maybe it's certain seats in each program, but I'd like to have some type of benchmark where we can say we will dedicate 5% of our seats this year to Indigenous applicants, and have those applicants reviewed in a different way than what we're currently using as our system. Yeah, absolutely. I would say that if you're looking at a program like speech therapy and audiology, let's use those. They might be very limited in the number of seats that they can have. So putting aside 5% of their seats might not be doable, or they might need more funding from the government to increase their enrollment. You're going to have those challenges. If you're looking at nursing, for instance, which has 120 students in it, 5% of the seats looks very different than that of a program that has 11, right? So I'm not sure that you can set a benchmark, but I'd like to look at some type of benchmarking. Maybe that's across a number of years. Maybe it's over 5 years, we'll commit 20% of our seats to Indigenous applicants. That's where I would start the conversation.